Good afternoon, and welcome to my first podcast, Faith Over Fear Ministries podcast. And I am joined here today with Dr. Gilmore, who is a breast surgeon at the West Cancer Center. Welcome to my first episode. I am so
Thank you. Thank you,
glad
Miss
to
Sims.
have you here.
Really
Um,
appreciate you having me.
Yes, we are going to jump right into it. We're going to discuss a few things about breast cancer, types of breast cancer, some advancements in technology, and we're also going to wind it up about some myths as it relates to breast cancer. So we're going to jump right into the first question. Can you explain, Dr. Gilmore, the different types of breast cancer and how they influence treatment
Sure.
decisions?
Absolutely. And again, thank you for having me. And I think this is a really important question because there are so many different types of breast cancer. And the first thing that I usually tell patients when they come in to see me is we really need to look at what does this look like under the microscope, because not all breast cancer is the same. I think a lot of people kind of assume that all breast cancer is similar, but the first thing we do in clinic is to go over the pathology report, which is what cancer do you actually have. And it's important to know that because your treatment might be completely different than your cousin's treatment or
Right.
your friend's treatment or something. And a lot of times it's really easy to say, well, my friend had this, so, that's probably what I have.
Mm-hmm.
But, it ranges from non-invasive cancer, meaning it can't spread, to other parts of the body, all the way to invasive cancer, meaning it has kind of moved out into the tissue. It has access to the bloodstream, and therefore
Mm-hmm.
it can spread to lymph nodes. It can spread really anywhere else in the body because blood goes everywhere.
Mm-hmm.
Even within the invasive cancer, we've got other different types within that. For example, hormone positive, HER2 negative breast cancer, that would be cancer that is responsive to hormones, the
Mm-hmm.
female hormones, estrogen and progesterone. And that can influence our treatment. We can give medications to block those hormones and therefore starve the cancer of the fuel it needs to grow.
Mm-hmm.
We have cancers that are more aggressive, meaning they've lost some of those normal hormone responsive abilities. We have cancer called triple negative breast cancer,
Mm-hmm.
meaning hormone negative, HER2 negative. Those cancers are, again, more on the aggressive side. They're usually higher grade, meaning more mutated,
Mm-hmm.
and they sometimes benefit more from the full body treatment, such as chemotherapies,
Mm-hmm.
immunotherapies, or targeted therapies, some of the newer therapies that we have. Um, there are there's another type called HER2 positive,
Mm-hmm.
which is another receptor on the breast cancer that we can now target. And that usually is chemotherapy and that targeted therapy to deal with that. And then on the most aggressive side, we see things like inflammatory breast cancer.
Mm-hmm.
And that's breast cancer that usually presents with clinical symptoms, meaning skin thickening,
Mm-hmm.
redness, looking almost like an orange peel. Those are signs that really need to be addressed because that can be a sign of a much more aggressive cancer.
I don't know if Ashley really told you about my I am finding since I've been diagnosed and I'm a survivor, of course, and then I'm talking, having conversation as I share my testimony with
Mm-hmm.
other women, and I'm finding that they are not having mammograms,
Mm.
and so I'm thinking that
Is that some of your friends around
it's
here?
some of my friends, either friends or people, or just having conversation with.
Mm-hmm.
Like if I'm invited to a party, and then I just start having casual conversation, and
Right.
I share that I'm a breast cancer survivor, and then I ask, "Well, when the last time you had a mammogram?" Oh, it's been 2 years, and
Mm.
these women are over 40.
Mm-hmm.
And just the other night, my son gave me a birthday celebration because it was really a celebration, birthday, and from the whole experience of being
Mm-hmm.
diagnosed with cancer
Right.
back in June. I got my diagnosis June the 2nd. So then that night, another one. I haven't had it in 2 years because of the radiation or something. I think it's gonna harm my body. I'm
Yeah,
like,
so there
it's so many myths
so
and
many myths out there.
misconceptions.
I mean, this is why I'm so glad you guys had me on, because I'm actually in the process of kind of doing my own initiative
Mm-hmm.
around screening and prevention. So
Right.
what can we do? Lifestyle factors, and then also, you know, you got to get your screening. I mean, even the guidelines are kind of the basic,
Right.
right? I mean, that's just kind of, you have to do it because we know with all cancers, it's the earlier the better. I
Right.
mean, it's less time to mutate,
But
more treatable, more curable.
and I guess I never would have thought that I would have been diagnosed. And then when I was diagnosed, I never knew. I knew it was. I heard of different stages, but I didn't know that there were different kinds.
Hmm.
And when I was told when I had my appointment with Dr. Fine that I had ductal carcinoma in situ.
Hmm.
And then that's when I started to do some research, and he told me it was non-life threatening, non-invasive. I didn't know in stage 0. I never knew anything
Right.
about the different stages
Right.
of stage 0. Never heard of a stage 0.
Well, we do it more stage zeros now because you were getting screening. I mean, getting mammograms is catching it early,
Mm-hmm.
and we catch a lot of the early stage with mammograms with calcifications that just show up.
Mm-hmm. And that's what I had shown up,
Right.
calcifications
Yep.
of my left breast. And then, the doctor was saying, well, we just out of precaution, we just want to. And I'm like, okay,
Yeah.
okay.
Yeah.
Whatever you got to do, let's do it.
Right.
When?
Right.
How soon?
Mm-hmm.
So, yeah, that's how I got here. And, of course, this journey has been, like I say, it has been very, I'm so grateful that it was caught
Yes.
early.
Yes.
And I do have the opportunity now to, I'm going to do some radiation therapy. I only have
Great.
to do like 5 treatments.
Mm-hmm.
And so,
Are you getting the partial radiation once every other day for 5
yes,
treatments?
yes, yes.
That's amazing.
Yes.
Again, and I think this is one of your questions that we'll get to, but
Right.
we're de-escalating a lot from where we used to be.
Right.
We used to never be able to do partial radiation, right? It had to
Mm-hmm.
be full radiation because, we thought that more is always better, and that's
Mm-hmm.
not necessarily the case,
Mm-hmm.
especially if you catch it early.
Right.
So it's not just about dying or not dying.
Mm-hmm.
It's about, even with the treatment, you could do a lot less treatment if you just catch it early. And that's what you're already seeing, which is
Right.
you're doing much less radiation than you would traditionally get. That's gonna be less side effects during the radiation. That's gonna be a better cosmetic outcome,
Mm-hmm.
afterwards. I mean, these are all things that people don't necessarily think about, and really, why would they? Because they're just walking around. They don't expect to get hit with
Right.
cancer,
Right.
but also, when you really think about it, and this is why I'm glad we're doing this, is just getting the word out there to
Yes.
say it's not just about survival, it's about quality of life, going
Right.
through the treatment.
Right.
So
Absolutely. And I'm just so thrilled to when I was speaking to Ashley about it, because I got all good news. And then on the flip side of that, I've had recently, a very, very, very close friend that we had a very strong bond, just buried her baby 2 weeks ago now.
sorry to hear that.
And when she found out she had breast cancer 6 years ago, she was already stage 4, but she found the mass under her arm.
Mm-hmm.
And so one thing just led for another. She never,
Yeah. Was she getting mammograms, or
well,
it's hard
it
to-
was, she was getting ready to relocate, and decide to have physical everything because her insurance was getting ready to change.
right?
And then she felt it. And so then she went to have it addressed. And then
Right.
by the time they did the biopsy and stuff, it was already stage 4, had already spread to her lymph nodes. And even when I got when I had my appointment, when I had my diagnosis, it wasn't in my lymph nodes, it wasn't no mass, it wasn't no nothing. And all that was like, whew,
Yeah.
it was just amazing. It's if you get those mammograms.
Hmm.
I mean, it can make a big difference. And
Huge
just
difference.
knowing the different types of breast cancer.
Hmm.
I would say if I would have known a little bit more, but it's something that you never think about. I mean, I would never thought about I would be diagnosed.
Right.
And I never skipped. And I think I've been having mammograms since I was 35.
Hmm.
But I never skipped, but I never thought I would ever have cancer
No.
anywhere.
No one thinks about it. I mean,
Mm-mm.
because a lot of these things are silent. I mean, at the end of the day, even, palpating something, she didn't have pain. She didn't
Mm-hmm.
have, something that was, really abnormally wrong with her other than just kind of, oh, feels a little different than
Right.
usual. But that's the thing about cancer is by the time you even have a subtle finding like that, sometimes it can be very much progressed. And so we have to rely on imaging. I mean, it is important to know the early warning signs.
Mm-hmm.
So that's education that I think, you know, everyone should know and, we should be talking about. But even with that, and getting your imaging, getting your mammograms, um, is so important, so critical, because the calcifications that you had, you would have never known about those. Those are
Would never know.
completely asymptomatic, no symptoms at all. Um, Also, women with dense breasts, they need to know that mammograms, in addition to something else, usually, such as ultrasound, MRI, something like that, is important, because mammograms are great, but they don't sometimes see everything.
Mm-hmm.
So, just a matter of getting your recommended screenings, as often as is recommended, and um, certainly for you, every year mammograms was critical. Breast cancer that you had was called ductal carcinoma in situ. That breast cancer is a non-invasive cancer, meaning that by definition it is contained in the duct of the breast. Okay, so those abnormal cells are still within the duct, and so they cannot get into the tissue where there's blood flow and the chance to spread to other parts of the body. Um, that's usually caught early with mammograms, with calcifications, with something like that. Um, in addition, there is invasive cancer. And invasive cancer is where, the cancer continues to grow and it invades outside of the duct or outside of the lobule into the surrounding breast tissue. And at that point, it does have a chance to spread elsewhere. It can spread to lymph nodes. It can spread anywhere else in the body, really, because blood goes everywhere. And the key is, what is the chance of that happening?
Mm-hmm.
And so, in order to look at that, we look at your pathology report, what came back from the biopsy. And that tells us a few things. It tells us, number one, is how mutated is the cancer,
Mm-hmm.
right? So, the more mutated it is, the faster it grows and the more likely it is to spread. And so, that's called the grade
Mm-hmm.
of the cancer. And you might remember that term being
I
used.
do.
Um, but that can range from kind of a grade 1, which is low grade, all the way up to
Mm-hmm.
grade 3, and that determines, with something we call the turnover rate, how aggressive does this appear to be. That affects our treatments, right? Because we will give different treatments for cancers that are more aggressive under the microscope versus
Mm-hmm.
less.
How has breast cancer surgery evolved in recent years with advancements in technology and techniques?
Yes, it's evolved a lot. um, if you look at 100 years ago, Dr. Halsted, really the father of American surgery, did something called a Halsted mastectomy, meaning
Mm-hmm.
he removed the breast. We'd remove all of the lymph nodes under the arm. We'd actually remove the chest wall. We thought
Wow.
that more surgery was better. But then we realized, about 50 to 70 years ago, that we don't have to be doing all that. It's really about, like we talked about before,
Mm-hmm.
what does it look like under the microscope? Because that really determines how do we treat it. And we realized we don't have to be removing all that tissue. We can just do sometimes what's called a lumpectomy,
Mm-hmm.
or just removing where the cancer is, giving you radiation with that. And that's equivalent in terms of how long you live to removing the whole breast. And so we realized that we can kind of downgrade
Mm-hmm.
some of the surgery that we do. There, depending on how it presents, how big is it in relation to the size of the breast, things like that. But we've started to do less. So over time, we started to do less. We're doing usually less surgery in the breast if we can. With the lumpectomy, we're doing less surgery in the lymph nodes. Okay, so instead of removing all of the lymph nodes, now we're usually just sampling the lymph nodes with something called a sentinel lymph node biopsy. That minimizes the chance of arm swelling. You may have heard of women getting arm swelling after lymph node surgery. That's a problem. It's called lymphedema.
Wow.
But we've reduced that now with some of the more modern techniques that we do. And now in older women, sometimes they're not getting any lymph node surgery. And
Okay.
so, we've really tried to start scaling back. And it's not only just with surgery, we're also doing this with our radiation, right? We're giving less radiation. Instead of doing whole breast radiation, sometimes we're just radiating part of the breast. And even the same thing with some of our chemotherapies. I mean, we used to basically give chemo to everyone who came in with breast cancer. And now we're using tests that look at the genes of the cancer, something called genomics, to figure out whether you even need chemo, whether you would even benefit from that. Because for some women, if they're not going to benefit from it, if they have a slow growing breast cancer, why would we give it to them? I mean, that's just
Right.
unnecessary side effects. So the benefit of all this downgrading of treatments is that we can treat the breast cancer and you can have similar outcomes while, having a better quality of life going through the treatments.
Okay, awesome. So, what are some of the common myths or misconceptions about breast cancer surgery that you would like to clear up? I know it's a lot of myths out there, and different women have different reasons for not even, even having a mammogram. But what are some of the myths as it relates to breast cancer surgeries?
So as it relates to surgeries, one thing that I hear a lot is, if you cut the breast, is the cancer gonna spread? Right? They think that just by making a cut, that exposes the cancer to air and it spreads somewhere else. And I think where this myth originated from was, if you think about it, back before we had all these full body treatments, before we had the pill to block hormones, before we had chemotherapy, what we didn't really have anything to treat the whole body. All we had was surgery. And so we would go cut it out, and then all of a sudden it would be spread somewhere else. And people would say, well, because you cut on me, it spread. So that's the problem. But in reality, what was actually happening is we just didn't have anything to treat the other areas. So that was going to come up. That was already there. That was already there, whether we were going to operate it on it or not. It was already spread. They just made the association because they got a surgery and then they saw it somewhere else. And so that's one that I really want to clear up, because, surgery is part of the cure, part of the curative intent. When we treat breast cancer, surgery is one of our treatments. It's not the only one, but it's certainly a major component of breast cancer treatment. And so, no, it doesn't spread when we do surgery on it. It's actually more likely to spread when we don't
Right.
remove it and things
Right.
like that. So,
And that's due to the pathology report because
Yes.
it's analyzed thoroughly
Yes.
before the treatment is recommended.
absolutely, we base all of our treatments on that pathology report.
Okay, we're going to just wind it up with one last question. Why is a team so important once you diagnose? I mean, you basically have a whole team that's going to really give you and join with you and make sure you get the best treatment that's possible
Yes.
as it relates to breast cancer and the surgery and the radiation. And why is that so important?
Breast cancer is a complicated process, and it takes a team to treat it. As cancer surgeons, sometimes people think, well, all we need to do is cut it out. I mean, why do we need all this other stuff? But the reality is, breast cancer is a microscopic disease, and this is what I tell all of my patients. Surgery is a key component of that and of the treatment, but it's not the only thing. We need the full body treatments. We need the hormone pills, the anti-hormone pills. We need the chemotherapy sometimes. We need targeted therapy. That's where the medical oncologist comes in. So they're kind of the medical cancer doctor. I'm the cancer surgeon And then we have a lot of other physicians involved. We have a radiation doctor who would be part of the treatment in some cases. We have other parts of the team, such as genetics, right? Genetic testing. We have genetic counselors. We have physical therapists, because sometimes after breast surgery, you need some physical therapy to get range of motion back, help with pain, etc. And then we have, even more supportive services, such as, mental health services, and nutrition services, things like that, that can be supportive in getting you through your journey,
Absolutely.
and are critical. And the other thing is, you know, I can only deal with what I'm seeing and the reports I'm getting, right? So you think about the mammogram report, radiologists are critical. So you have to have a good radiologist giving me the
Yes,
information to say
absolutely.
this is where the calcifications are, or this is where the mass is. And then you also have to have a good pathologist, because they're the ones actually reading the biopsy. And like I said before, we act on that pathology report. So those pathologists have to be, really good. And a lot of times we'll have kind of more complicated cases. And so we'll do things called tumor boards or tumor conferences, where we all come together basically at a conference table and
Wow.
say, it's a brain trust, essentially. It's we all put our heads together on what is the best treatment for you individually. And so that's why when you're choosing where you're going to get treated, those are considerations. Is, you know, do they have this multidisciplinary team really working together on your behalf? Very
Wow.
important. Yeah.
Very important. Well, I thank you so much, Dr. Gilmore, for joining me here today. And this has been a lot of good information. And I've always believed knowledge is power. And I absolutely thank you so much for sharing your expertise with us today in this audience. You can go back and watch this podcast and get a lot of information. I thank you so much. But stay tuned for future podcasts and Faith Over Fear Ministries. Thank you so much for joining us today. And until next time, stay safe.
Thank you.